Hello. Welcome to the next session of the COVID inquiry. We're going to be looking during this session at what's been going on with the NHS. One of the frightening and most difficult parts about dealing with the COVID inquiry has been with the crisis has been the fact that the NHS has been, well, frankly, overwhelmed. There was lots of concern in March and April that we'd end up in something like the situation that was seen in Lombardy early on. We stopped a lot of elective care. We did huge amounts of things to try and preserve the capacity of the health service so we could deal with the oncoming waves of care. And one of the problems we're going to face as we head into the next few years is going to be the long tail of people whose treatment and care was delayed for good reasons to try and preserve that that capacity in future years. It's not going to be a thing that we get over quickly. I've got family members who work in the NHS, and particularly around cancer care. The extent to which we've had very serious problems, and are going to have very serious problems with delivering basic things that people basically expect from the NHS over the next few years as we run through our backlog, is one of the things I'm hoping that we're going to be able to deal with today. So I'm just going to point you to the chat. This is a bit unlike a normal thinking because we're not really seeking, if you like, our normal set of contributions. We're not asking people to put their hands up, but my colleague Kim is in the chat and would really like to hear from you if you had first-hand experience of some of the issues that we're talking about. Now, some of these will be very difficult and personal, and we really appreciate your care and help and candor in this stuff. But what we really don't want is for it to be an entirely high-level event with no heart. The intention of this inquiry is that we will eventually get through to coming to a conclusion about where things went wrong and where they went poorly. I wrote last week a piece about how one of my concerns is that we've underthought about how much of a long tail this event will have on public services for years to come. So I've got some excellent guests here today, and I really want to start actually with we'll move through them in turn, but I'd really like to start with we have a particular actually interest in cancer care. My apologies, I'm having very slight technical issues that are causing me some slight concern. I'd like to start with Linda Thomas, who's the CEO of Macmillan. Macmillan is a cancer charity who are perhaps one of our best known cancer charities that do a range of things, particularly in the operational space. One of the things I'm really keen to get to grips with is that it'd be really helpful to hear from you, Linda, about how things have gone for Macmillan's patients. Is this a story about, if you like, disruption of ongoing care, not starting new care? Can I ask you a bit about how it was for your staff on a practical level, testing, support, isolation, that sort of thing? And then can we perhaps have a quick chat about what the backlog looks like?
Yeah, so thanks very much and good morning, everybody. It's really great to be here talking to you today. So I think for us, the story was a really complicated picture, and it's almost impossible to kind of go back to March and remember how everybody thought and felt during that time. But with the stay-at-home message, there was a very clear remit then for cancer patients feeling that they didn't need to come forward and present with symptoms. So the first thing we saw was referrals just went through the floor, and they went down to levels that we had never, ever seen before. And even in September, they're only back up to 95%. So we're doing a good job of getting them back up. But that has resulted in about 50,000 missed cancer diagnoses during the period between March and now. And that's obviously a great concern. The second thing that happened was that treatment it just got completely disrupted for very, very good reasons. And I'm really not blaming the NHS or any staff working in the NHS. Some things had to be paused. Some clinical decisions had to be made. So, for example, operations had to be postponed because there simply wasn't the capacity to do it. With things like chemotherapy, radiotherapy, where staff try to keep those going as much as possible, there were issues around infection control, and it just became very difficult to maintain treatment levels. So treatment levels also went down. Obviously, that was really, really serious for patients and such an anxious time for them. I heard from patients who were literally on their way to hospital when they get a call saying their cancer surgery had been cancelled. I think anybody who's watched the hospital programme, which has featured the Royal Free, the first episode of that's all it dealt with was cancelled cancer operations. And my heart really went out to the doctors and nurses treating those patients, because you could see how much it meant to them to try and get the operations back on track. But for very understandable reasons, we've ended up with a fairly significant backlog. I think then finally, just to talk about Macmillan staff. So NHS professionals who I believe have been unbelievably brilliant during this pandemic. Macmillan professionals, obviously no exception there. They've done great things. But unfortunately, a lot of people were redeployed. So they were taken off their cancer care duties and they were put onto COVID wards and moved to intensive care and critical care. And again, for very understandable and good reasons. But this also meant that even for patients then actually getting into the system and being treated, their care was done very, very differently. And, you know, the picture for cancer patients has really been such a difficult period. We know how hard it is getting a cancer diagnosis. It has been unbelievably difficult with COVID and cancer. Patients having to go in and get devastating news, sometimes hearing the news that they've got cancer that can't be treated and can't be cured, and they're on their own in the hospital with their loved one waiting in the car park to be told that news when they come out. And, you know, anybody who's ever been in that situation, you know, 2 members of my close family were diagnosed with cancer a few years ago. You need to take somebody with you because, boy, you don't hear anything after you've heard the words you've got cancer. So I hope I haven't painted too bleak a picture, but I think it has been a really difficult year for patients with cancer. And, you know, we've had to try and do everything we can to support those patients. So, you know, I'm pleased to say that Macmillan has pulled out all the stops to do that. And we're left now going into the second lockdown in a so much better position than we were in March and April. But we are estimating that it will take 20 months to clear the backlog, even within cancer services. So hope that gives you what you wanted, Chris.
That's very, thanks ever so much. My apologies for the technical problems I've been having, afflicting Southeast London. Can I actually, should have gone to Harini first to begin with our sort of opening statements. But I hope that Harini, if we can come to you now, you know, you can draw on that to take us through and sort of set out some more of the backdrop to what we need to get through today.
Good morning, everyone. As you know, the Tortoise COVID inquiry aims to create an independent examination of the UK government's handling of the coronavirus pandemic. And today, the issue before the inquiry is that COVID is not the only killer in town. Thousands of patients have missed cancer screenings and checkups during the crisis, and mental health issues have escalated. And the question for the tribunal today for the inquiry today is there a silent secondary pandemic waiting in the wings for the NHS? The inquiry this morning will hear from the following witnesses: Chris Hopson, the NHS Providers Chief Executive; Ian Lush, Chief Executive of Imperial Health Charity; Linda Thomas, CEO of Macmillan Cancer, who's just spoken; Dr. John Williamson, Anaesthetic Registrar in North London, and also photographer and author of A Patient's Progress. And the head of the inquiry today is Chris Cook, the editor of Tortoise Media. I'll start by setting out the background to these questions for this morning's session. In 2004, the Labour government set the standard of reducing waiting times for NHS elective care at 18 weeks. That seems to be a political target. To what extent does it have meaning in relation to the health conditions which NHS patients actually experience? To what extent does that target matter? How does that differ for different health conditions? How does that differ for different patients in different communities? The pandemic has highlighted an issue which has often been overlooked through British awkwardness, one of which is different health outcomes for different races and different communities. Before the coronavirus pandemic began to affect the UK, the NHS already faced a backlog of patients who were substantially behind on waiting times for their treatments. More than 1 in 6 patients were waiting more than 18 weeks for routine treatment. 4.4 million patients were on waiting lists, of whom 730,000 had waited over 18 weeks. In January 2020, non-urgent planned care was postponed for 3 months from the 15th of April 2020 to clear the backlog and meet its own standard of treatment within 18 weeks. The NHS would have had to treat an extra 500,000 patients every year for the next 4 years. However, rates of spending growth set out in the NHS funding bill in February 2020 were insufficient to cover the cost of meeting the 18-week standard by March 2024. That was the position before the pandemic affected the NHS. Without a radical intervention to increase capacity, current infrastructure and staffing levels cannot meet the standard of the 18-week period of treatment by 2024. In other words, at least hundreds of thousands of NHS patients were going to be waiting in excess of 18 weeks for treatment for the foreseeable future, even without coronavirus. But what happened next? On the 5th of March 2020, the Chief Medical Officer, Chris Whitty, announced that the UK did not have enough hospital beds to cope with projected COVID infections. 12 days later, NHS England directed all trusts to cancel non-urgent surgeries for the period from 15th of April to 15th of July 2020. In April 2020, there was a fall of 57% in visits to accident and emergency compared to April 2019. To what extent does this mean that people who were not using A&E efficiently in 2019 have avoided wasting NHS time in 2020? And to what extent does that mean people are simply not getting the urgent care they needed at the time they needed it, and their health needs will now escalate? On the 22nd of April 2020, Cancer Research warned that 2,300 people each week may be missing a cancer diagnosis as people were avoiding seeking the medical advice and care which they normally would have sought. The government response was a public information campaign claiming that the NHS was open for business and urging patients not to miss treatment. On the 28th of April, just 13 days after NHS trusts had been told to cancel treatments until 15th of July 2020, the government advised trusts to step up non-COVID-19 urgent services as soon as possible, countermanding the earlier instructions to suspend them for 3 months. How did these changing instructions affect planning, organisation and budgeting in NHS trusts? To what extent was the countermand an inevitable part of fighting a new and unpredictable pandemic? To what extent were NHS England's instructions to NHS trusts below the standard which patients and trusts should expect? What's the current position? Although planned treatment is resuming, safety measures to prevent the spread of COVID-19 in the medical setting are complicated and expensive. Waiting lists for non-urgent procedures now contain over 4 million people. In contrast with the 18-week standard, prior to March 2020, only a very small and stable proportion of patients were waiting for over 1 year. Now, over 100,000 patients have waited over a year for hospital treatment. The challenge of catching up affects various sectors. Staff. The NHS is one of the 5 biggest employers in the world, and its staff are often considered to lie at the heart of its sustainability and success. Between the 9th of March and the 25th of May 2020, however, 1,600 working age health and social care staff died with symptoms of COVID-19. 92% of NHS Trust chief executives say they are concerned about staff well-being, stress and burnout. In regard to planned treatment, a survey by Cancer Research in May 2020 of 1,900 cancer patients found that 1/3 of them had had their treatment impacted by the pandemic. Cancer Research estimated 38,000 fewer treatments had taken place than normal between March and July 2020. By October 2020, a survey of 420 GPs found 45% knew of a patient who had come to harm because of delays in routine care caused by the pandemic, including additional waits for diagnostic appointments, urgent cancer referrals, cancer treatment, surgery, and outpatient appointments. One of the 420 GPs reported a patient who had died whilst awaiting the rearrangement of heart bypass surgery, which had been cancelled because of the pandemic. Another GP reported a patient who had died awaiting a delayed investigation into weight loss and dysphagia. A third GP reported several examples of what could realistically be deaths due to delayed or cancelled care. The Nuffield Trust analysis of NHS waiting times shows a steep increase in all regions of England in the period from January to June 2020 in the share of patients waiting over 18 weeks for planned treatment. The increase is approximately threefold. Less steep but also significant is the number of patients waiting longer for treatments which were not stopped but were delayed. Around 1 in 20 people diagnosed with cancer waited over a month for treatment over the summer of 2020, and the trend appears to be one of increase rather than peak and fall. In regard to diagnostic delays, whilst everyone's eyes were on COVID tests, there was a sharp fall in diagnostic tests for other conditions. Usually, the NHS undertakes around 2 million diagnostic tests each month, including ultrasound and MRI scans. In April 2020, this fell to 600,000. In the first 9 months of 2020, compared to the same period in 2019, the NHS carried out 4.6 million fewer diagnostic tests. By mid-April 2020, routine GP referrals had dropped by 90%, and the 2-week referral period for people with suspected cancer had fallen by 67% of referrals. Compared to April 2019, when 170,000 urgent referrals for cancer investigation or treatment were made. In April 2020, 80,000 such referrals were made, which is less than half. What will the costs be in terms of death, disability, reduced quality of life for patients, and increased pressures on the NHS in the future? One of the words of the year for 2020 is said to be unprecedented. A team of staff from 6,813 surgeries, nurses, doctors, and assistants due to be allocated on a rota basis will now face an unprecedented effort to administer a new urgently prepared vaccine. Finally, I turn to mental health care. The charity Mind reported that urgent and emergency referrals to the NHS of people in mental health crisis in June and July 2020 were the highest since records began. A mental health crisis can include self-harming, psychosis, attempting suicide, or a manic episode. There was a 15% increase in such referrals overall from March to July 2020. That included a 19% increase in people detained under the Mental Health Act who were admitted to acute beds. Mind received twice the usual volume of calls to its helpline in November 2020. Likewise, the Royal College of Psychiatrists reported a rise in both the severity and the number of emergency interventions. The number of people in the UK suffering from depression has increased. Rates in June 2020 were almost double normal rates for the month of June. What is the current position? Despite the great patriotic love of its NHS, the UK Health Service performs towards the bottom of the league of wealthy countries in terms of the availability of key staff and bed capacity. The NHS's baseline capacity on key measures such as beds, nurses, doctors, and capital assets before the pandemic began was low compared to other wealthy countries. The UK spends significantly less on healthcare capital as a share of GDP compared to other rich countries. How should we assess, plan, and budget for the catch-up operation for the NHS? What standard should be set? Is it enough to catch up to the place at which the NHS would have been but for the pandemic? Should COVID-19 be a prompt to review the 18-week target? Should COVID-19 be a prompt to review NHS staffing and pay structures? How should priorities be set for the recovery of the NHS? Whose needs should rank above who else's needs? Does the NHS reinforce structural inequalities between different groups in society, including the racial inequalities and different outcomes which the pandemic has put into the public gaze? Should the pandemic be a prompt to shake up the NHS? Key questions for this inquiry must include the following. What should the treatment plan be for the recovery of the NHS from COVID-19? And is the NHS destined to suffer from long COVID?
Thank you ever so much, Srini. That's enormously helpful. Can I come now to Chris Hobson? Chris is I don't know what the right word is, what the right noun is for you, Chris. A sort of a panjandrum in the health service, a long-standing figure in the public sector and public policy. And NHS providers represents the hospitals in the effectively in the health service. Yeah.
A hospital, community, mental health and ambulance trusts, so all 217. So it's not just hospitals, it's the full range.
Sure. Okay. And can I ask where you think, to go back to the questions I asked Lindsay, the how you felt the service dealt at the beginning with all of this, with where things were? Can I ask how you think the things are set in terms of the backlog that we now have to work through and where things are going forwards?
Okay. Well, I thought Linda was very helpful in terms of just reminding us of that context back in, and you did too, Chris, in terms of that context where effectively when coronavirus first hit, we were kind of looking at what was going on in Italy and Spain, where there was a real sense of overwhelm. We had no idea about how rapidly this was likely to spread. We had no idea about how quickly, but also how many cases we were going to deal with. We obviously did projections, as you would have expected us to, and on that basis, we identified the need to create 33,000 beds for coronavirus patients. That's what we did. And I have to say, it was absolutely extraordinary, the effort that NHS staff put in to do that. I mean, we've never done anything remotely as complex and difficult and speedy as that. As it turned out, we didn't need all of those beds. And you might say, thank goodness we didn't. But clearly it did have an impact on the other treatments that we were providing. And I thought Linda's organisation has done a great document called C, the Forgotten C, in terms of just documenting some individual case studies about what's happened. And we've already heard some of those today, and I'm sure we'll see more in the chat box. And I think all of us in the NHS would want to recognise the impact this has had on individuals. I think the bit that's important to remember, Chris, and it's not easy to calibrate, is there were some people who were suggesting that the NHS was a COVID-only service for March, April, May, June. That's simply not true. What the NHS did was it prioritised on the basis of clinical need. We continued to treat emergency patients. We continued to do the most urgent emergency treatments. We, for example, had 1,800 on average babies a day being born. So all of the things that absolutely had to be done, as many of them as possible, we did. But yes, we have had to delay some care. I think what's really important, and again, we just need to tease this out, is there were two different things going on here. One is the NHS did have to delay some treatments, a significant number of treatments, but also secondly, patients weren't coming forward. And I think, again, Linda highlighted that about, the fact that people were nervous about kind of coming forward for care. So what we have now got is a very significant backlog. What's been happening over the last few months is that the NHS has been trying to recover that backlog as quickly as possible. If you remember, what happened in August was that the NHS was set a bunch of targets. Everybody, us included, said they were incredibly stretching. And actually what happened is, surprise, surprise, we met them in September. What's happened in October is, as the second phase has hit, of COVID has hit, we've had to slow down that rate of backlog recovery. So we are now left, and again, Harini, I think, set out some of the statistics, we are left with a significant elective care, in hospital elective care surgery backlog. I wouldn't particularly quarrel with Linda's 20 months for cancer. I think for us, it's going to be a large number of months, stroke a small number of years to get through that backlog. And then I thought I was particularly pleased that Harini at the end was also then talking about the mental health issues that we're now experiencing. If you talk to every single mental health trust chief executive, what they're saying is they're seeing an explosion in demand in terms of very significant large numbers of extra patients are now starting to come through. Our view is that is going to continue very significantly over the next few months and probably years. And I think the questions that Harini put are really important, which is how are are we going to deal with that backlog? Again, you may have seen, Chris, we sent a personal letter to the Chancellor to basically say he had to put some money into the 21-22 spending review to start that process. An extra 3 billion was allocated, but I don't think any of us should pretend that that was anything other than a start on what is going to be an enormous effort. Just one final comment, Chris, and again, I thought, if I may say, that I thought Linda's tone was absolutely perfectly judged in terms of recognizing the fantastic effort of frontline staff. I do think we need to recognize that staff have been working absolutely kind of flat out, and I wouldn't want one hint of, you know, a sense that somehow the NHS or its staff have actually kind of been, you know, deficient here. My argument would be that we've been on the end of a unique global pandemic that we've never seen before. The NHS has done its best. I'm sure we could have done some things differently, but this is a very unfortunate and difficult set of circumstances. And now NHS staff are working as hard as they can to recover that backlog.
Can I ask, Chris, I wonder if it'd be helpful to understand some of the sort of, if you like, some specific sort of clinical pathways on this. So by that I mean, are there types of elective care that have just not happened for the last few months? One of the things that someone told me was that so ongoing, say, cancer care has happened. If you've started a course of treatment, it will continue. But for example, marrow transplants aren't happening because of the specific difficulty of dealing with that sort of transplant. So there are people who are sort of not able to progress their treatment. Can you just take me through some of the things that are definitely, you know, that sort of thought?
Well, so I thought Linda, again, was really helpfully referring us to the hospital programme. And I thought what was really helpful in that programme is it gave you, and if anybody's not watched it, I really would encourage you to watch it, because those first 3 episodes absolutely showed exactly what's going on. And what you'll find is that, is exactly as you say, each specialty has got its own particular kind of dynamic. So again, as Linda referred to, we know, for example, that endoscopy and colonoscopies have particularly been difficult because of the need for very, very deep cleaning, and therefore, you know, the rate at which we can do endoscopies and colonoscopies has actually significantly dropped. Therefore, all of those specialties that require that kind of diagnostic testing have been probably more hit than some others. But it will vary also by not just specialty, but by individual hospital. This is one of the bits that's quite complicated, is some hospitals have found it actually relatively easy to create additional extra capacity, because they've got the ability to do so, diagnostic capacity, by, for example, building temporary capacity in car parks. And they've done some amazing things, very innovative things. So it will vary significantly by each individual, exactly as you're suggesting, by each individual specialty. And it will just vary again about which particular hospital we're talking about. And you know, if you look at the data, what you'll see is that, and again, Linda, I thought, brought this out, is that we have recovered in some specialties. We're absolutely back to the kind of volumes that you were seeing this time last year. In some other places, particularly places where, for example, you have got pressure on diagnostic capacity, or, for example, where you're particularly dependent upon invasive surgery, surgery that requires fairly rapid turnaround, but you've got a don and doff PPE, which significantly lengthens the time required. Those are the kind of places where you're getting pressure. Just one final point that I just thought the hospital programme absolutely brilliantly illustrated was what you've got at the moment is vast numbers of people who need theatre time, in other words, time in operating theatres, all massively clamoring for what is limited theatre space. And you simply can't build theatres on the back of a, at the drop of a hat. And what you find, and again, I thought the Royal Free Stuff really showed you this, was that we're having a very complex task at the moment in trying to schedule all of that extra demand into limited theatre capacity.
Right. Thank you ever so much, Chris. I'm sure we'll come back to you. Could we come next to Ian Lush? Ian is the Chief Executive of the Imperial Health Charity and has been since 2014. Ian, so can you tell us briefly what the Imperial Health does, and what your experience has been of the pandemic in those sorts of same terms, in terms of what are the things that weren't being done, what are things we're now doing, and what does your backlog look like? I'm also really interested, I should say, in the the staff side of this, which is to say, how have we, how effectively have we been able to keep staff safe as they do this stuff and support them to be safe for patients?
Sure, thank you very much. Well, we support 5 hospitals of the Imperial College Healthcare NHS Trust. That's St Mary's, Charing Cross, Hammersmith, the Western Eye, and Queen Charlotte's Maternity Hospital. And I think it's safe to say that they were really under pressure in the months between March and perhaps mid-July. But we did everything we possibly could as a charity to help the staff. I think actually the hidden cost to the staff will still be emerging. One of the things that the NHS charities generally are funding is staff wellbeing. And we've seen a lot of call on the counselling services. It's really effectively post-traumatic stress in many cases. So we've, for example, my charity, we've paid for 7 extra counsellors to join the contact service, which is the counselling service for Imperial. But I think, it is undoubtedly an incredibly difficult time for the NHS, as Chris was saying, as Linda has alluded to. But I think we also should just recognise what they did achieve. I know from personal experience with my colleagues in the Trust senior management that, it was a really difficult challenge, and they feel they rose to it pretty well. Now, at the moment, things are difficult because there are still COVID patients, but they're trying to redress that and try to treat things. What I think has been quite interesting is that some of the learning from change of working patterns in the first few months of the pandemic can actually be put into practice longer term. So, for example, is it really necessary for, say, follow-up appointments for cancer patients to always get them into an outpatient clinic? Well, no, it isn't. You can actually do a lot of that by phone or by Skype or by other online methods. And that's something that some of us have been banging on about for ages. We've funded refurbishment of some of our outpatient areas, which really weren't great. But actually, I'd rather be funding better use of the technology to prevent people having to come into hospital at all when they're just having a quick routine checkup. The same is true with A&E. Now, Harini mentioned, well, has some of the A&E decline been because actually people were kind of misusing A&E and maybe needed to be triaged through 111 or through urgent care. Now, that's not to say that if you've got something really serious, you shouldn't come into A&E. Of course you should. But actually, some of the numbers in A&E are still down because people are actually using the service better. And that has to be a good thing. But as charities, I think we are very concerned about the mental health issues, which you've highlighted, both patients and staff. I should declare an interest in this. My wife is an NHS psychotherapist, so she's seeing a huge pressure on their services. But also, I think we are helping to work with our hospital colleagues through NHS providers and through the other umbrella bodies to say, well, what actually could we do differently? How can we spend our money? You'll know that NHS charities collectively have raised over 150 million on our appeal. How can we use that money to actually look at some of the service delivery as well as supporting staff and say, can we do it more effectively? So I think there are some real learnings from this, but at the same time, yes, I think it's been a really difficult time. But I think we should remember how brilliant some of the NHS staff have been.
Right, and so I mean, your I should declare an interest that one of my family members has benefited from the Imperial charity. So thank you for that. But a lot of what you traditionally do in these sort of the NHS adjacent charities is, if you like, a lot of it's sort of building through capacity that would otherwise not be not come through. And some of what you do is, I hope you don't take this as a derogatory when I say it's sort of softer things about hospitals.
Yes, absolutely. I mean, we are not there. We're not there to replace government funding. And that's very clear. And it was a concern raised when, Captain Tom was walking up and down his garden. There was some stuff on social media saying, why is this man having to raise all this money when we pay our taxes? Well, it was nothing to do with the taxpayers' money. What we were doing is things like patient support. We provided iPads, it's a generic term, tablets, they're cheaper than iPads, for patients so they could see their families when they were in hospital with COVID. And stuff like that would never happen through Treasury funding, But yeah, a lot of it is the softer stuff. We run the volunteer service, for example, and they've been hugely helpful during COVID. But actually now there are significant sums available, so we can work on some maybe harder outcomes, and I think that's really important.
I mean, I raise the softer stuff partly because I think that's one of the things where people felt like the circumstances of the pandemic had made things really grim. So the volunteers weren't there as they normally are, and the family couldn't come in and all that sort of stuff. Being ill was a much more distressing experience during the pandemic than it would have been normally.
Yeah, absolutely. And that's true very much for our volunteers who weren't able to go onto the wards, which was, something that we really pride ourselves on, is the befriending and all of that. And that's something that had to stop. We were able to have volunteers in the hospitals supporting staff through food parcels and wellbeing packs and so on. We are gradually getting volunteers and our arts practitioners back onto the wards, but it's a really slow process involving testing and so on. We have provided quite a lot of online support. So we're doing befriending online now. So we have volunteers for long stay patients, communicating with patients through video calls and phone calls, just to give them somebody to chat to as well as their families. But yeah, that's a real challenge. We hope that obviously with the vaccine coming in, that next year we'll see us being able to restart services like that much more widely. And the same with our arts program. The arts engagement work is incredibly valuable. A lot of it is now therapy based, so we do arts therapy, and that's been mainly paused. So again, we really hope that with better testing and with the vaccine, that will be able to restart.
Okay, thank you ever so much, Ian. Can we come to Dr. John Williamson? I think John is interesting for lots of reasons, but one of them is because he's a photographer who we've published some bits of. But also, John, you're an anaesthetist, and anaesthetists are interesting in a pandemic, it turns out, because the things you normally do have been disrupted in lots of ways. So surgery has, a lot of that was basically stopped, like lots of elective surgery for long periods, but also you're people who are very good at putting tubes into people. So you got lots of you, and I got redeployed into intensive care and retrained. Can you talk to us about, if you like, what the difference in your life was from, say, this time last year to the pandemic, and how it affected your working patterns?
Yeah, sure. Thanks for having me. Great to be here. So our working life substantially changed. The build-up was almost worse than the pandemic. We didn't know what was coming. There were huge system shifts in how we were going to work and do our work. Things involving how we're going to use PPE, where patients were going to go, all these new pathways, even how we did procedures changed to try and limit the spread of the virus when we were doing the procedures. All the elective operating obviously stopped. There's multiple reasons. We didn't have the staff to do it. We were also planning to have COVID patients overspilling into our recovery area in theatres, which did happen. And also having the theatres available for COVID patients to even be intubated in theatre. Due to this, we needed more staff, so our rotas changed. We were on a more frequent, intense rota. The consultants were going from being out of hospital overnight to being in hospital overnight. We have more than one consultant who was in hospital overnight, which you never normally see. We were being redeployed to other areas such as intensive care and doing the outreach work for intensive care. So going onto wards with these critically ill patients who would normally be in an intensive care setting, in a ward setting, and overseeing the use of complex devices such as positive pressure breathing devices for these patients. So yeah, it was really quite extraordinary how the shift of our work pattern changed. And this was across other specialities. The surgeons obviously stopped operating, so they were trying to find things to do, shifting to doing telephone consults. Yeah.
And how, if you can forgive the question, how are you? Like, how was it?
It was very intense, actually. I think it hit us when everyone saw what was going on in Italy, even before it hit the mainstream media, that everyone's always got links through people they know working in other healthcare systems. So we knew what was coming and we didn't think we were prepared. And it was a tremendous strain trying to figure out how we were going to go about doing everything. I think during the time period, you do get in the mentality that you're just going to get on with it. And the saving grace, I think, of the NHS, again, is just your relationship with your colleagues and the support you have within your team. You do often feel slightly alone in terms of the wider picture and governmental support, or the picture that's painted of what's going on not being realistic. But certainly you sort of support each other through it. But I mean, everyone was exhausted after the first wave started to come down. You could see that in the staff. People just needed a bit of respite. We're trying to get back to operating, but all the patient pathways were obviously changing. So it wasn't an easy thing. We'll just go back to doing our theatre list. It was, how are we going to do our theatre list now? All the patients need to be going to a different ward area. Have they been tested in advance of coming into hospital? Their swab's not back. We don't have capacity to test them in this period of time. So are they going to have to wait on the ward to have their emergency surgery before they're going to a different theatre? And you could see that over the summer, people starting to get back to it, then preparing for the second peak, basically, and then it's just kind of continued. So yeah.
Can I ask, is there, so I mean, Anesthetist is quite as I mentioned, quite a, sort of an interesting, I mean, I think the traditional joke is that you spend most of the day doing the crossword, but during the pandemic, your expertise at running respirators and ventilators and helping people to breathe, is a core part of what you actually do in a normal thing. So you've obviously been enormously useful to your, as a broader sort of form of capacity to the hospitals. Can I ask, are there things that you've done in the last 6 months that you've just never done before? I mean, technically, things you've had to learn to do.
No, not really. I think our job's not very well known what we get up to, but we're sort of the overseers of the whole patient pathway through operating, so optimizing patients, seeing them through theatre, seeing them through their recovery period, looking after them in intensive care. So our job is really looking after critically unwell patients in a variety of settings, whether it's A&E or intensive care, cardiac arrest on the ward. So it was a familiar role, but expanded and working a lot more. And I think lots of my concern about what some of the speakers have touched upon about trying to build back and the capacity that we have, I think staffing has always been the rate limiting step behind even the headlines. They'll say, oh, but we've got this many beds available. It doesn't account for the care that's required. For example, for these COVID patients, where you'll see this from some of my photographs, you'll have 7 or 8 people around one of these patients trying to turn them over. And when you're doing that for a whole ward, we'd spend 3 hours as a separate team just going around the intensive care, just turning patients over. It's a huge effort from staff for different illnesses and different requirements. And you can't just magic up staff out of nowhere to try and fill in the hole for this deficit that we've got. The motivation also, you'll see day to day, whether a theatre list finishes on time or has to cancel patients or exceeds expectations, is very much dependent on staff morale and the drive of this complex team involving normally around 8 or 9 people for one patient's journey. All has to come together, and all the staff need to be available and on form and motivated for it to work. So it's a really complex task.
Thanks ever so much for your time, John. Can we go to Baroness Morgan? Baroness Morgan is the Chief Executive of Breast Cancer Now. And so I mean, we've focused a lot on cancer because I feel like but I think for good reasons, because it's one of the, you can't get it right without getting other things right. So it's actually quite a useful sort of barometer for lots of bits of the system. But Baroness Morgan, can you just talk me through your experience of how of the last year really, and what your concerns are about where we are? What are the things we need to get up and running again? What are the things we stopped? And I mean, I think I would stress, I think there's I've not heard any sane person ever sort of suggest that the issue is there's an issue of fault about the NHS in lots of the stuff, even if we sort of in retrospect can work out there are things we may have done differently.
Absolutely. I think I would want to really strongly emphasize that, focusing on blame at this stage is really not going to be a very helpful way to go. And I think, when we think about the experience of the last well, really since last year, from my point of view, leading the charity, one of the biggest impacts for us has been, we provide support and information and face-to-face services to people diagnosed with breast cancer, and we fund, or did fund, about a third of all the breast cancer research going on in the UK. And so from the charity point of view, we've been through a period of massive change with really significant drop in income. And, we've had to put our research on hold, we've had to cancel programs, we've had to reduce the services that we can offer and pivot everything onto a kind of digital and get our helpline and so on working from home, our helpline nurses working from home. So there's been all of that going on in terms of running the charity that supports people affected by breast cancer and the research community. And then, as Linda and others have highlighted, the kind of tumultuous change going on with service provision for people affected by cancer. And there, I think I would want to focus on, to start with, there was an assumption made, Chris, I think you might have mentioned it, that once you start treatment, it carries on. Well, there is a really significant population of cancer patients, breast cancer patients with metastatic breast cancer, where it's treatable, but it's not curable. And at the beginning of the pandemic, NHS England and NICE issued guidance setting out that these people with incurable cancer were of a lesser priority than others. Now, obviously, we raised that as a real issue of concern for people living with incurable cancer, and the government stressed, the NHS England, in fact, stressed that people should be treated as individuals, and the feedback that we've had is that it's very difficult to know whether that guidance was used very much. But that is one example of a change which caused so much distress to people with incurable breast cancer, some of whom need regular tests, regular evaluation of their disease to see whether it's progressed and to see whether or not they can move on to different types of treatment, and see involvement in clinical trials, which have been very much put on hold, or were very much put on hold to begin with. That their involvement with clinical trials as their only hope in some cases. So right at the very beginning of the pandemic, there was this real sense of fear for the very, very for some of the very unwell cancer patients, and also that issue about there's nothing. What can you do if you're from a health professional point of view? What can you do if you know that your patients are at an increased risk because of COVID, and how on earth do you balance all of that? And I suppose I think the professional communities in the breast cancer space really got together and worked together tremendously to kind of overcome these kind of initial challenges, and to get really great communication going, and to do absolutely their very best to support people. But they're working up against these almost kind of insurmountable challenges. We as a charity, we evaluated the impact of the pandemic on screening. Now, breast screening is a very, very important tool to promote early diagnosis and make it possible for people diagnosed with breast cancer to access the best possible treatments as early as possible, before the breast cancer itself can be felt. Now, we saw, in comparison to pre-pandemic times, almost 1 million women were missed their invitations for screening. Now, screening services were put on pause, as they had to be at the time. There wasn't an easy way out of that. But there's been lots of talk about backlog. Those screening services are up. We estimated about 8,000 breast cancers that would have been detected were going undetected. We're absolutely sure that those 8,000 breast cancers will not have been detected yet. The screening services are up and running, but the backlog is massive. And then one other point about backlog: the most common kind of breast cancer is estrogen positive breast cancer. So in all the figures showing that we've got treatment going up for once people are diagnosed to acceptable levels, the majority of women with breast cancer, their treatment for estrogen positive breast cancer, they're being put on hormone therapy and their surgery is on pause. Now, very shortly, it will not be safe for those women to be on pause, and they will need to have their surgery. And that is, that's going to be a real challenge for the system. And it's great having access to all the independent sector capacity and so on. But, those backlogs are a really serious challenge. And the workforce issues that we had before the pandemic are not going away.
Thank you ever so much. I think I'll come back to one or two of those thoughts. Can we go back to Linda, who unfortunately got the double ignominy of me mispronouncing her name at the start, as well as accidentally being dumped in before our opening statement as I struggled with my computer. Linda, can I ask about one of the things I'm sort of interested in that Dennis raised was also on drug trialing as well. So has that sort of been able? So one of the things that people may not appreciate about cancer in particular is the volume of patients who benefit from clinical trials at any given moment is not insignificant, right? There's a sort of, not least because obviously it means that we have a future pipeline of drugs that we understand, but also because you get the drugs in real time. What's happened to that during the pandemic?
So Delith, I can see you on my screen. Nod if I'm saying the right thing and don't if I'm not, right? Because you've got a lot of experience in this. But my understanding was that during the pandemic, during the first wave, clinical trials, access to clinical trials stopped. Is that right? Yes, Dalith is nodding, so that's really good. So that means for a significant period of time, there were no clinical trials happening at that point. My understanding is now they have resumed again. I think one of the things we've got to do is we can't stop that happening again. And again, I think one of my overarching messages would be we need to learn lessons from the first wave, and whatever happens now, and nobody's pretending winter's going to be easy. And even though we're all excited about the vaccine, this could go on for several months yet. We can't stop treatment. We shouldn't stop access to clinical trials, and we absolutely can't stop screening again. So there's some serious messages there for government and NHS England about making sure we protect cancer services now as we head into probably the most difficult part of winter.
Right. And can I ask if you could have one thing from government right now, Linda, like you're allowed one wish list, one thing, one silver bullet, what is it? What is the thing that we need to do over the next sort of 6 months?
I am going to pick, because there's many subjects here, I am going to pick the prioritisation of a long-term funding plan for the NHS workforce. We had massive problems before we went into COVID with staff in the NHS being burnt out and not enough. For example, we need an extra 2,500 cancer nurse specialists, and that's only cancer. I would put that back on the agenda and accelerate it, because with a burnt out workforce that are being asked to work all the hours God sends as we go into a Christmas break, deal with the second wave of COVID and deal with the backlog catch up, we've got to protect our staff. I mean, they're amazing people, but they can't carry on forever like this. So government, put the money in, put the training in, and get that workforce problem sorted.
Okay, that's very clear. Can I come back to Chris Hobson? I have sort of two questions. One's come from the chat. So on that last thought, you mentioned earlier, I think, that you'd asked for 3 billion from the Treasury as your next Christmas present. Can I check what, if you like, the key component driver of that is? Is it that you have a sense that you need to up output over the next few months, or is it more about backfilling holes and fixing some of those workforce issues?
Sorry, so thanks, Chris. Can I just also answer the previous question very quickly? Can I just channel my old colleague Jeremy Hunt and basically say, I think he's called for, which seems to me to be a very good idea. We need a costed, funded, timed plan for how we're going to get through the backlogs. And effectively what we need to do is, and I think you need to give us a bit longer to work out exactly what they are going to be, because I still think we've got people who haven't kind of come forward. So we just kind of need to identify exactly what that's going to be. But I think it's realistic to ask the NHS to come back probably, I would say, in 3-4 months' time with a very clear plan of how we're going to, over the next 2 years, in what order, what prioritization, how long it's going to take us, how many people we're going to need, but also have that fully funded. So that for me, I think would be the real priority that we need. Sorry, and your question was, Chris?
So the one was on the sort of the 3 billion. What was that, if you like to
cover? So the three. So basically, what we've traditionally done when we've had an elective surgery backlog of the type that we've got is effectively what you pay for is extra kind of extra list clearance in terms of people being paid overtime to work extra shifts. What you also then have is you buy the independent sector capacity in order to kind of get through those. Use that capacity to get through those lists. So that's what we assume that 1 billion of the 3 billion will be used for. Then, again, just to reinforce, we need to talk about the mental health stuff separately. I think the mental health stuff feels to us to be different in that what we can probably see is, let's say, 3 or 4 years worth of effectively extra capacity needed in order to deal with what we hope might be a bulge that then goes back down again. So that 500 million of the 1.5 is going to be devoted to that. You've then got 375 million of that. And again, Linda's really pointed this out, and I think Dennis pointed it out too, diagnostic capacity. So 375 million pounds to invest in diagnostic capacity. And then the reality is that the rest of it, which is 1.125 billion, is effectively being spent on the fact that the NHS is going to have a gap next year in terms of it's going to be unable to realise the efficiency and productivity savings that it was due to be making. And in order for us to carry on doing just what we're doing, that gap will need to be filled. But as I said, Chris, the key to remember is this is just the start of this process. And effectively, that's why I asked for my timed fully funded plan. I think this plan will stretch into 22-23. My suspicion is it will probably spread into 23-24 as well. So we need to have that plan clearly laid out, and we need the government to commit funding for that plan in the context of the whole NHS budget.
And just the other thing, so one of our guests raised in the chat was about the discharge decisions early on. There's been obviously a lot of scrutiny about. Can you just take us through what? Yeah, I know that you.
So I could do that for half an hour, Chris, but you'll probably want me to do it in a couple of minutes. So what we know is that in order to create the capacity for those 33,000 beds, we had to discharge patients at pace. What we know at the time was there was insufficient testing capacity in order for those patients to be fully tested. So what happened was, as they were discharged, most of them went home, some of them went into care homes. There has been a really important question around, was the spread of coronavirus in care homes due to that discharge and due to the fact that testing was not available at that point. What's really interesting is, and you'll remember, Chris, I'm sure you followed this in real detail, there was quite a big and prolonged and really quite pointed debate. What's happened since, and particularly recently, last couple of months, is some more evidence has come forward, which has really been based on the genetic sampling of the COVID-19 strains in care homes. And you're therefore able to identify where those strains have come from. And what the evidence from that shows is that, interestingly, it wasn't NHS discharges that was primarily responsible for that. It was actually care home workforce who effectively were spreading. And as we know, particularly at kind of the lower end, the state-funded end of social care, what happens is you have large numbers of agency workers who move between different care homes. And the formal evidence, there's a report that Sage produced, which effectively says the highest correlation of COVID spread in care homes was actually due to workforce spread and residents amongst themselves spread. It wasn't NHS discharge spread. There's a whole bunch of stuff on our website, including a quite detailed document that we wrote 2 or 3 months ago, which really sets out this in more detail.
It wouldn't be a proper discussion about the NHS without me concluding by saying we really should talk more about social care. So it's very the traditional ending for this conversation. So look, we've hit 10:15. Thank you ever so much for your time. I think I'm sort of persuaded by Chris's argument that it feels like it's almost like, I think we called it the reset we had a few years ago, where effectively the NHS was given a new set of targets in exchange for a load of more cash, then as a sort of with a trajectory, an understanding of where things needed to be. But I'm quite struck at the point of the subtext of my question, Chris, about the 3 billion was 3 billion is kind of standing still money, right? It's sort of, it's not progression money. And the one of the things I think is most important for people to take away from all of this is that the extent to which the crisis, the acute crisis is over. We now move into a chronic phase, and which will take the form of backlogs. It'll take the form, as Della said, of sort of getting people back into screening, of finding cancers that we normally would have found before. It'll take the form of restarting some of the softer stuff. As Ian talked about, it will take the form of trying to get sort of the pipeline rolling again, as Linda sort of laid out. I think there's the extent to which that we are still only in the foothills is one of the things I think we've brought out from this. And I think the extent to which whatever the plan is, it's not about the next 6 months or the next year, it's about a longer term strategy. I think Dr. Williamson's observations about life on what staff have done are really powerful and important. He made a point in the chat about morale, and I think the idea that, as it seems to be the current sort of conversation, the idea that the public sector in general can hope to run off its backlogs, and remember, it's not just hospitals that have backlogs, schools effectively have learning backlogs too. There are lots of things that are going to have to pick up a lot of pieces. The idea that public sector pay is not going to rise and it's going to be able to something we can suppress over the next few years is something I'm really skeptical about if we're going to actually keep public services more broadly on their feet. We should of course fix social care again, like a simple thing. Thank you ever so much for your time. Our next session is on the media. Did the media fail? And it will start in 15 minutes. I think it's obviously something to look forward to for ourselves to finally get beaten up by someone. But thank you ever so much for coming. We'll see you shortly.